So our NICU is one of 18 regional perinatal centers in New York State. It's located in Westchester County, north of Manhattan, and provides care for and covers an area associated with 25,000 deliveries in the region. When compared to the other 18 regional perinatal centers, we have the highest number of extremely premature babies, or meaning babies born below 28 weeks or birth weight below 1,000 grams. Nutrition in the beginning, as soon as the baby is born, is provided by parental nutrition. So we have developed a very vigorous protocol with maximum protein intake and optimization of caloric intake and macronutrients, micronutrients, and trace elements within the first 3 days of life. We then implement enteral nutrition as soon as we think that the baby is ready. Enteral nutrition does not proceed very easily because these babies are premature or very critically ill. Their digestive system, even though is anatomically ready, functionally is not yet ready. And for that reason, we have to target their enteral nutrition according to their readiness to take it. Enteral nutrition also goes hand in hand with the clinical condition of the baby. There are obviously certain conditions that require a much higher nutrient intake and much higher caloric intake. And the best way to assess whether a baby is receiving an optimal nutrition is by monitoring growth. If a baby is on exclusive now enteral feedings of parental nutrition, we target a minimum of 120 calories per kilo per day, 4 grams of protein per kilo per day, 3 grams of fat per kilo per day, and about 8 to 10 grams of carbohydrate per kilo per day. We additionally provide calcium and phosphorus through human milk fortification with a target calcium intake of about 1 millimole per kilo per day and a calcium to phosphorus ratio of 1 to 1. We provide all the essential vitamins in the feedings as well to ensure that the babies have adequate vitamin D, vitamin A, vitamin E, just to mention a few. At this point, yes. We have routinely utilized standard fortification, adding 4, 6, or 8 calories extra, assuming that the mother's breast milk or the donor milk that we're using is 20 calories per ounce. We are in the process of developing individualized fortification for patients. At this point, the goal will be to reach to 24 calories or 26 calories. Eventually, we will develop even more individualized nutrition protocols based on the patients also their own growth rates. Macronutrients in the breast milk are not only nutrients, they actually serve a biological purpose. Many of the proteins in the milk have a hormonal effect on the babies. Also, if we're not optimizing nutrition, we may trigger states of stress and inflammation. And so for that reason, it's extremely important to look at all macronutrient intake. We found that you cannot assume what is in the milk. You actually have to analyze it. The macronutrient contents of the milk depend on the gestational age when the baby is born, on the postnatal age of the baby, on the diet of the mother, on the her psychological well-being, on the her diet, and also on the style with which she's collecting the milk, whether with electrical pump, manual pump, or hand expression. Therefore, you must analyze the milk to ensure that the baby is receiving the optimal nutrition by the milk alone, or if you choose to add fortification, to know what will be your final, to know where you're starting, and when you fortify, what's your final product.